Good, af Good afternoon, everyone. I'm Dr. Susan Kahn, the co-director of the CanVector Network, and I'm very pleased to welcome you today to the CanVector National Thrombosis Seminar Series for 2021-2022. After the success of our inaugural series last year, CanVector is really thrilled to be able to kick off our second year of the series of live monthly virtual webinars featuring state-of-the-art thrombosis and venous thromboembolism lectures presented by both Canadian as well as international experts. I'd like to just take a moment to thank our planning committee for this year's seminars, in particular the chair of the planning committee, Dr. Maral Koulian, as well as both Jesse and Caleb behind the scenes who are working to make sure that this all happens very smoothly. Our planning committee is working on a great lineup of seminars for this year, and we greatly appreciate their time and efforts. There's some more information about the seminars on this slide, and I think we can move on to the next slide. I'd also like to highlight, as co-director of the network, that we have recently announced a very special collaboration or partnership between our network and the CPTHN, the Canadian Pediatric Thrombosis and Hemostasis Network. The mandate of CPTHN is shown on this slide, and we feel that the missions of our two networks align significantly to be able to offer resources, content, and opportunities that benefit all of our members and facilitate collaborative work among our members on projects and research in the field of thrombosis. And I'd like to thank the chair of the CPTHN, Dr. Christine Sabapathy, for working with our executive team these past few months to make this collaboration and partnership possible. And we greatly look forward to having CPTHN members take part in upcoming CanVector events and also signing up potentially as CanVector members and receiving our communications. And today's seminar is certainly a great kickoff to this collaboration. So welcome to CPTHN. Now, I was going to turn the presentation over now to the host of today's seminar, Dr. Marie-Claude Pelland-Marcotte, but I understand that she is stuck for a few more minutes in clinic, and I will therefore introduce the first of today's two speakers. And I also just want to mention that if you have questions during these talks, you should send them, put them into the chat, type them into the chat at any time. Actually, not the chat, but the Q&A, because there will be a 15-minute Q&A period at the end of the presentations. So it is my great pleasure now to move on to introduce Dr. Ketan Kulkarni, our first speaker. And presumably Dr. Pelland-Marcotte will be able to join us in time to introduce our second speaker. But Dr. Kulkarni is an associate professor in the Division of Hematology Oncology at Dalhousie University, and his research interests include pediatric thrombosis, supportive care in oncology, and microbiome research in pediatric oncology. He's interested in studying adverse events related to cancer and its therapies, central venous catheter complications, and survival outcomes. And he's actively involved in collaboration with basic and translational researchers in a diverse array of fields within medicine, as well as mathematics, bioinformatics, and epidemiology. And the overall goal is to find innovative ways to improve the care of pediatric hematology oncology patients. I think I will skip the very long introduction, but obviously you have a very interesting and relevant background. And I will say welcome. We're very pleased that you're speaking today, and I'll ask you to take the podium. Thank you. And you just have to unmute Dr. Kulkarni. Yeah, please unmute yourself. The bottom left. There you go.
Okay, did that work?
Yeah, perfect. Welcome.
Perfect. Thank you so much. Sorry about that. I couldn't see the button. It disappeared. So thank you, Dr. Khan, for a very kind introduction. And I'm really delighted to be here today presenting at this seminar series. So without further ado, I'll maybe get started. Sorry, I'm trying to advance the slides. Yeah, there it is. So the topic for today is really try and sort of explore some of the current challenges around CVC-related thrombosis specific to pediatric population. The objectives of this talk are to try and discuss some of the key epidemiological questions as they relate to CVC-DVT in the pediatric population. And then we can try and discuss some of the risk factors and diagnostic challenges surrounding pediatric CVC-DVT. And then maybe we'll try and go into some of the clinical impact and management issues in the area, and maybe round up towards the end with some of the key questions that we face and some of the future directions in relation to this field. So I'm hoping that this is going to be pretty interactive, and I'm going to request people to please type in their answers in the chat box. I do have the chat box here on the right. So what do you think CVC-DVT comprises of in terms of proportion of VT in pediatrics? So let's see what people think. Do you think it's less than 10%, 10 to 20, 20 to 50, or 50 to 80%? We'll give it like 15 seconds maybe. Okay, we've got a bunch of answers. I think D seems to be the winner right now. So it is D. So in sharp contrast to the adult world, where, you know, CVC-DVT are much less in proportion, a large majority of the DVT in pediatric population are central venous line related. So studies would tell us that 50 to 80% of them are central line related. So that makes central lines one of the most important, if not the single most important risk factors for thrombosis in pediatric population. So much so that, you know, recently we designed a perioperative thromboprophylaxis algorithm for our surgical patients. And I think this is pretty small to see, but we assigned a score of 1 to any patient who had a CVC. So CVC is being recognized as the most important risk factor, and many of the scoring systems that exist all over the world will automatically assign at least a score of 1 if a pediatric patient has a CVC, regardless of the type or the duration of the CVC that exists. So I just wanted to highlight the value of CVC in terms of risk factor for thrombosis. So then going on to risk factors for CVC-related VT in the pediatric population, this itself could be sort of a topic for a whole day worth of conference, and there's a lot of conflicting data. So if we can probably divide these risk factors into patient-related risk factors and CVC and insertion-related risk factors. So just similar to the pediatric VT, given that majority of them are CVC-related, there's a bimodal peak in the incidence, with neonates and infants having the highest risk, and then the risk drops a little bit. And then as patients get into the double-digit tween years and then the teenage years, the risk goes back up and further goes up into the A by A population and keeps increasing as age goes up. So we see a nice sort of a bimodal peak in the incidence. Underlying diagnosis is also among the most important risk factors. Similar to the adult data, cancer patients have an especially increased risk. We're going to hear from Uma next about cancer VTE in pediatric population. Cardiac patients are also very high risk, with up to 50% incidence of thrombosis in that population. Trauma, TPN, patient with renal disease, and other miscellaneous conditions are also important. Critical illness such as ICU stay or neonatal ICU stay is also recognized as one of the key risk factors for pediatric CVC-related DVT, because a lot of patients in those situations will have a CVC. We're going to spend one slide on thrombophilia, so I'll skip that for now. Similar to the adult data, we have identified in the pediatric population that non-O blood group increases the risk of CVC-VT or VT in general. A previous VT also increases the risk. So these are some of the patient-related risk factors. If we then look at CVC-related risk factors, the type of CVC carries a special importance. In most of the studies in pediatric population, and also in our own experience in the Maritimes, PICC line seems to be the bad actor. So we found up to 9% incidence in cancer patients who had a PICC line for thrombosis. So we definitely need to be pretty careful in terms of judiciously using PICC lines. That is followed by Broviac or Hickman lines in terms of risk, and then ports. Number of lumens is inconsistently associated, but as you could imagine, the higher the number of lumens, the bigger is the catheter. And given that increases the catheter to vein ratio, that increases the risk of thrombosis. Data on material of catheter is pretty inconsistent in pediatrics, so we'll probably park that for future. Site of insertion has been identified as an important risk factor. So if there's subclavian insertions or femoral insertions based on the Parker and the PROTECT studies from the past, that has been identified as a risk factor. If the tip of the catheter is non-central, that is not in the SVC, that can confer a 2 to 3-fold increase in risk of thrombosis. Similar to the adult data, given the anatomy of the venous system, a left-sided catheter is often deemed more troublesome than right-sided catheter. But then again, it's not conclusive. Data on ultrasound guidance, personnel expertise, and duration of CVC is much more conflicting in pediatrics than adult data. The infusate, so the type of infusion that's going in, also is identified to be a risk factor. So prothrombogenic or thrombotic infusions can be much more thrombotic than a simple saline infusion, for example. So the big question becomes in pediatrics, should we really worry about thrombophilia? So most studies, and a lot of them emanate from Canada, have shown inconsistent association with only 5 to 10% patients known to have had a prothrombotic risk factor in pediatric studies. So we do not recommend routine testing at the present time for inherited thrombophilias. It is also known from literature that inherited thrombophilias do not predict the risk of recurrent VT in children who need a new CVC or have had a history of previous CVC VTE. So really, thrombophilia doesn't help us one way or the other. It might help us in terms of making treatment decisions or thromboprophylaxis decisions, but in terms of identifying the risk for CVC DVT, it seems to be much less important than adult data. So coming back to a question, next we might try to see sort of what would we classify as a CVC DVT. So which of these would you classify as a CVC related thrombosis? Option A is an arm swelling in a child with ALL with a double lumen port and radiologically documented subclavian occlusive VTE. Option B is a partially occlusive VTE in the axillary vein in a 13-year-old with a PICC line, cystic fibrosis as a background diagnosis, and they had an ultrasound for a lung cyst. Option C is a fibrin sheath at the line tip on a screening echo in a patient with a congenital heart disease. And option D is fibrosis at the antecubital vein in a 5-year-old with a PICC line on TPM. Let's see what people think. Okay, we got an A. Any other thoughts? Okay, we got an A and B. So, A, almost everybody would agree that A definitely is a CVC VTE, but then a debate ensues when we start talking about B, C, and D. So depending on who you ask, CVC VTE is a true raging controversy. Even when we did the systematic review last year, it was really quite difficult to come up with a more consensus definition. And this is actually a subject of an international guideline right now, where we are trying to really assign definitions using consensus methodology to see if we can have an international standard on how we are going to define and identify and classify CVC VTE. So hopefully we'll have that work out soon. Most people would agree with this type of classification, that a symptomatic CVC VTE is any VTE that's radiologically documented with any clear signs or symptoms of VTE. Majority of the people, but not all, would agree that CVC dysfunction should be considered as a symptom of CVC VTE. Not all studies agree with this though. Then the big category is that of asymptomatic VTE, which may be identified on a surveillance scan or maybe incidentally identified like the option C. Some people call incidental VTE an accidental VTE or an episodic VTE. And there's a lot of controversy on whether or not fibrin tip should be considered a precursor of the clot itself, or whether or not it really does increase the risk of clots. So that's open to much further discussion. So let's try and ask a little more questions around the types of CVC VT in pediatrics. So do we think most of the CVC VTs in pediatrics are symptomatic, B, asymptomatic, C, both, or D, unclear? Okay, we seem to have a quick consensus on that one. So yes, indeed, a majority of the CVCVT in pediatrics are asymptomatic. So if we combine that with the first question, majority of the VT in pediatrics are CVC related, and majority of the CVCVT are asymptomatic. So then the next question is, how many of the patients with the CVC develop a symptomatic VT? Option A is less than 5%, option B is 5 to 10%, option C is 10 to 20%, and option D is more than 20%. Okay, B seems to be the winner so far. Any other thoughts? Yeah, and that is the correct answer. So I think, Mary Claude, you were involved with some of this work, and also Leo has been involved with a lot of these systematic reviews. And data would suggest that 5 to 10% of the patients with a CVC will develop a symptomatic VTE. Now, this is in sharp contrast with the overall incidence of CVC-VT, which has been reported from anywhere such as 0 to 70, 80%. So we can easily see that majority of these clots are truly asymptomatic, with a very small proportion being symptomatic. So then the next question becomes, which of the following are precursors for a CVC-VTE? Option A is CVC dysfunction. Option B is mechanical dysfunction. Option C is infection. Option D is fibrin sheath. And option E is any of the above. Klassen thinks it's E. Anybody else? Okay, that's great. We've got a lot of E's. We've got A, B, and C. There's some controversy in fibrin sheath. So really, this is another great topic for debate. And the best available data would suggest that A, B, C are definitely up there, and possibly fibrin sheath is also a precursor. So the best possible answer is likely any of the above as risk factors. So this is some of our recent data, which we just completed in terms of analysis. So we looked at over 5,000 patients from our center who've had a CVC in the last 15 years or so. And we found a proportion of patients with mechanical dysfunction, and this is sort of a risk exposure curve against time for mechanical dysfunction. And we looked at various types of mechanical dysfunctions and various types of lines. This is quite hard to read, but these 4 graphs show a variety of lines, and the incidence of mechanical dysfunction was quite consistent over the last 15 years. And now we're trying to correlate that with the incidence of clot, and clearly there's a pretty good association there. So CVC dysfunction is also a topic of much interest, and almost all of us would have used TPA many times or routinely to resolve CVC dysfunction. In our own local study, we had identified in this paper here that about 20% of cancer patients experienced at least one episode of CVC dysfunction. There is a lot of variation in guidelines on when to do a chest X-ray, when to do an ultrasound, when to do a linogram, and how to resolve CVC dysfunction. But the key point here is that CVC dysfunction is associated with VT in cancer patients. This has been shown by our European colleagues before, and in our very own study, we were also able to show that one or more episode of CVC dysfunction was very significantly associated with developing a future symptomatic clot. So definitely CVC dysfunction is a precursor for thrombosis. Moving on to clinical impact of CVC VTE, for sure we know that a major thrombotic VTE leads to treatment interruption. So in cancer patients or cardiac patients, that's a huge issue, because now we have to deal with that first and interrupt whatever treatment is going on. CVC-VT also leads to CVC loss and replacement. We had shown previously that even when there's mechanical dysfunction or CVC dysfunction, even that is associated with increased requirement of CVC. So we had found that the average, this is in cancer patients, but we had found that the average patient needs 1.5 CVC, and if they required 1 or more TPA, they had 2.05 CVCs, and if they had more than 2 TPA, they had 2.3 CVCs. So the effect was incremental up to 2 episodes of dysfunction, and then it leveled off. But then the sample size for patients requiring 3 or more doses was very small. So both CVCVT and precursors of CVCVT are probably associated with increased line loss. There is some data that a CVCVT can develop post-thrombotic syndrome. That is subject to further studies and tests, but seems that majority of these PTS are more benign and not giving too much clinical symptoms. There's very little data on whether or not CVCVT leads to PE, but there are anecdotal reports that it can lead to pulmonary embolism, including asymptomatic VT. So we do have a large study ongoing where we're trying to collect all asymptomatic clots and see what their clinical outcome was and whether or not there was any PE with that. So this is a topic of much controversy. We had previously seen, now that was 2 or 3 years ago, that patients, cancer patients with VTE have a significantly worse outcome as compared to those without VTE. So this is shown in this little graph on the right side. So this was patients without VT, and this was leukemia lymphoma patients with VT. This was sarcoma patients without VT, and this is sarcoma patients with VT. So we found a major discrepancy in their survival outcomes. And similarly, Mary Claude led this study that was at a national level using CIPSI database, and they found, this was in leukemia patient, and found similar increased risk of worse survival outcome in patients with CVCVTE. Now, majority of these cancer VTE patients are CVCVTE, so we need further studies to specifically look at whether CVC and non-CVC related VTE make a difference in this population. And I know a number of groups are looking at that. But again, this association has been inconsistently reported, and Uma's group actually did not find this association. So we really need larger powered studies to really identify whether CVCVT is an adverse prognostic marker or not, at least in cancer population. Furthermore, there's some evidence from St. Jude's, and then Uma's group had done some of this work. We also found a couple of years ago that there was poorer survival outcomes in cancer patients who had 1 or more episodes of CVC dysfunction. So further supporting that truly a CVC dysfunction is not a very benign event, and it may truly be a major precursor of thrombosis. So then the next question becomes, if there is a CVC-related VTA, should we take the line out? And the current consensus is that we do remove the line if it's not needed, and if it's not functioning. But if it's needed and truly needed, it's in correct position and functional, then we can continue use and treat the patient with CVCVT. Moving on to treatment of CVCVT, there has been a lot of movement in this area. Traditionally, we would have used unfractionated heparin, low molecular weight heparin, or fondaparinux as our options for treatment. But there's a lot of upcoming data on DOACs, especially from the Einstein Jr. CVCVT data, so there's very promising role for DOACs in this population. There is no role for routine thrombolysis in this population, and that's not recommended outside of a study setting. Once again, this year, the KID trial was published as an abstract in the ISTS 2021. So that showed non-inferiority of 6 weeks of treatment if the clot was not occlusive at the end of 6 weeks of treatment. So I think further data in that direction will help us to identify optimum duration of treatment. Majority of people would agree that as long as underlying risk factor continues, such as cancer treatment or cardiac problem, most patients with CVCVT should receive secondary prophylaxis to prevent a secondary clot in a patient who has had 1 episode or more of CVCVTE. So really moving on to burning questions, we're not very sure whether or not asymptomatic VTE associated with CVC should be treated. Paul Monagal's group from Australia showed no impact of asymptomatic CVCVT in his population, and that was published in Blood a couple of years ago. We're also not clear if primary thromboprophylaxis clearly reduces the incidence of CVCVTE. Dr. Brandeau's group has done a couple of systematic reviews that show inconsistent conclusions. We know Maureen O'Brien's study from COG. I'm not sure if the results are still reported. I looked yesterday and I didn't see any clear indications yet. So we're still not clear whether primary thromboprophylaxis is indicated or is not. As I mentioned before, we need a more definitive nomenclature on asymptomatic VTEs, and hopefully we're going to get that work out and going, and we'll have a more consistent data in that direction. We do need more defined role of novel anticoagulants, especially in high-risk patients. So if a cancer patient, with thrombocytopenia or some other comorbidities, whether or not we would use rivaroxaban is a good question right now. We need more data in that direction. We're not sure of exact duration of optimal treatment. So, in summary, our future directions really tell us that CVCVT are here to stay. Likely, we will see an increase in the number of CVCVT. We need much larger pediatric trials to answer these key clinical questions, which means we need collaborative studies. And we're really looking forward to upcoming data on DOACs. And we really don't know, we haven't gone into too much of prevention and mitigation, but whether or not bonded catheters would do the same magic like in the adult world, or whether or not the material of catheter matters are good questions, and whether or not primary prophylaxis with heparin or such other substances works is unclear. I'm going to stop there. This is some of the funding support we've had for a variety of our heme and oncology studies. And of course, there are a lot of people to thank for all the research work that is being done. And this is a beautiful view of our sunset of a famous destination called Peggy's Cove, and one day late at night, I captured this when no one was around. So I think I'm going to stop there and hand over back to Dr. Khan.
Thank you very much, Keithan. This is Marie-Claude. I'm going to present next Dr. Uma Atali for the second part of the talk. Sorry for being late. So sorry about that. So let's get started. If you have any questions, just don't forget to put them in the chat. And at the end, we'll have a 15 minutes period for questions. So Dr. Uma Atali is an associate professor in pediatrics at McMaster University with research interest in thrombosis in children with cancer and supportive care in children with cancer. Dr. Atali's research focus is to evaluate epidemiology, risk factors predisposing to thrombosis, and development of preventive and therapeutic strategies for thrombosis in children with cancer. Dr. Atali published multiple reviews evaluating the epidemiology and pathogenesis of thrombosis in children with acute lymphoblastic leukemia in the context of their disease, therapy, and inherited and acquired prothrombotic defects. For study analysis of our institution experience of thrombosis in children treated on Dana-Farber Cancer Institute ALL study protocol, identify older age and high-risk ALL as risk factor for thrombosis. She did also epidemiological studies that have shown that thrombosis is a common complication in children with sarcoma and lymphoma and other types of cancer. Her current research aims at comprehensive evaluation of prothrombotic risk factors predisposing to thrombosis in children with cancer and to develop a predictive model to identify patients at high risk of thrombosis. So thank you very much for being here. I'll let you the stage.
Hi, everybody. Good afternoon. And thank you so much for CanVector to invite me for giving this talk. I thought I'll just discuss some epidemiology of cancer-associated thrombosis. And I'm going to go back to my first slide to say that I would like to discuss a case-based challenges in management of cancer-associated thrombosis in children. We'll take an example of ALL-associated cerebral synovenous thrombosis, which I'm sure the oncologists face quite often and call the hematologist for the help. So we'll briefly review the epidemiology of cancer-associated thrombosis, identify the difficulties in anticoagulation therapy in children with cancer, and evaluate available evidence for management of anticoagulation therapy in cancer patients. And then see where the research needs to go. So SS is a 7-year-old girl with high-risk ALL receiving induction therapy according to the COG ALL therapy protocol. On day 8 of therapy, that is after 4 days of asparaginase, she was brought to the emergency room by ambulance because of generalized tonic-clonic seizures at home and developed a right hemiparesis. An urgent CT scan of head showed an occlusive sagittal synovenous thrombosis with intracerebral bleed, as shown in the right side here. This is not her picture, but just adopted from one of the things, but her bleed was quite extensive. There is also this empty cellular delta sign here. So she was admitted from ER to PICU and followed with urgent MRI with MRV and MRA. So questions that this case raised are how common are VTs, especially CSVT in children with cancer? How do I treat this patient? And what to do with her induction therapy and overall ALL therapy? So there is very little data, even now. Like I was just talking to Ketan yesterday that I looked at my old slides and been keeping up with the literature. There is not much progress made in this field. We still have the same problems as we had faced about 10 years back, that the data are mixed, prospective versus retrospective. The thrombosis reported are either symptomatic versus asymptomatic, and there are varied treatment protocols. So it's very hard to say what is the exact incidence of thrombosis in children with cancer. Children, as you know, that my slides are acting up, but anyways, going back, children have idiopathic VT is very rare in children because of reduced potential of thrombin generation and increased capacity to inhibit thrombin, as well as enhance antithrombotic potential of vessel wall. So compared to adults, the risk of thrombosis is very low, but recent data have shown that patients who are hospitalized would have anywhere between 100 to 1,000 times higher risk of thrombosis. So it seems that thrombosis in children is a phenomenon of sick children. What about thrombosis in children with cancer? The incidence of symptomatic VT varies, and it's reported to be about 1 to 16%. It's protocol specific and depends on scheduling of asparginase and steroid. Asymptomatic thrombosis could be anywhere in the range of 40 to 50%. Most of the incidence is dependent on type of publication as well, whether it is single institution versus multi-institutional. As if it is for ALL, what about other cancers? VT is present in about 16% of children with non-ALL cancers, including lymphomas and acute myeloid leukemias. Over 60% of children with VT had cancers other than ALL. So it's not just a phenomenon for children with acute lymphoblastic leukemia. About 20% of children with solid tumors, that is sarcoma or Wilms tumor or neuroblastoma, were reported to have thrombosis. Surprisingly, children with brain tumor tend to have significantly lower incidence of T. Gliomas in adults have much higher risk of thrombosis. CSVT in ALL is about 2%. So a recent study by NOFO and our study, which will be soon coming up in pediatric blood and cancer, have shown that CSVT constitutes about 2.5% of all thrombosis associated with acute lymphoblastic leukemia. And it constitutes about 20% of all VTs in this patient population. So this is mostly for the learners in the group, if there are any. So why do patients with cancer develop thrombosis? As we know, this is a multifactorial condition. Problems related to the host, problems related to cancer, that is thrombin generation, procoagulant activation, angiogenesis, and metastasis. Therapy-related problems, which Ketan has eloquently told us about CVL, so I'm not going to go there, but chemotherapy, mainly asparginase and steroids, as well as these days anthracycline, cisplatin have been implicated in activation of thrombosis. And add to that the immobility and stasis. Prothrombotic defects of host are controversial. European studies have reported to be significantly affecting, whereas those from the North American studies don't show that the prothrombotic defects play a major role. Non-O blood group is being shown. Our studies and systematic reviews have shown that non-O blood group increases the risk of thrombosis in both ALL patients as well as non-ALL patients. So in general, if somebody has a cancer, the risk of thrombosis increases. And who are at risk of developing thrombosis? Briefly, presence of CVL is the major risk. Age of the patient, type of cancer, type of chemotherapy, and ABO blood group are so far known risk factors. The probable risk factors could be thrombophilia, the risk of ALL, T immunophenotype, presence of mediastinal disease, In recent PBC, there is a study published for thromboprophylaxis for mediastinal masses with patients with lymphoma and cerebral dysfunction. Can we predict cancer-associated thrombosis in children? Leslie Michel has published a validation of the predictive model for increased risk of thrombosis. However, that seems to be particularly relevant to the certain protocols being used. We recently published guidelines or guidance document, not guidelines, guidance document for identification of at-risk patients and prevention of thrombosis in cancer patients. We feel that secondary, it is easy to advocate for secondary prophylaxis, but use of primary thromboprophylaxis is still quite in debatable situations. So going back to my case, how do I treat the CSVT ALL in this patient? Do I use anticoagulation therapy? When do I use it? Which is the best anticoagulant? How long do I treat? What do I do if the patient is thrombocytopenic? How to adjust anticoagulation for LP and other invasive procedures? And what is the role of antithrombin supplements? Can these patients receive further asparaginase, and when can I start the asparaginase? Those are very practical and day-to-day questions that we all face. So let's talk about anticoagulation therapy, to do or not to do. If I don't treat the clot will progress and that will cause more problems. But if I treat the patient who is already receiving myelosuppressive therapy and is at risk for bleeding, would have excessive bleeding. So what is the recommendation? There are not much evidence if you do systematic review. There are no data in a form of RCTs with low molecular weight heparin or not without anything. So the guidelines so far say that adults with cancer and TE, symptomatic or asymptomatic, are almost always treated. However, there are no strong evidence or guidelines for children with cancer and thrombosis. However, because of the risk of progression and recurrence, current consensus is that children with cancer and symptomatic thrombosis should be treated promptly and aggressively with anticoagulation therapy. How about CSVT? ASH 2018 guidelines by published in Blood Advances state that although the evidence is not very strong, because of the risk and life-threatening situation, with or without hemorrhage, both patients with CSVT should be treated with anticoagulation therapy. What is the best anticoagulant agent for my patient? The common choices of anticoagulant agents are unfractionated heparin, low molecular weight heparin, or oral agents. Typically, vitamin K antagonists are not preferred in cancer patients because of various reasons like poor intake, potential drug-to-drug interaction, longer half-life, and difficult monitoring. So we have either, we go with low molecular weight heparin. I'm not going to talk about DOACs or other agents that are not commonly used still. The low molecular weight heparin is preferred in adults with cancer. However, similar data is not available in children. The consensus of experts suggests that low molecular weight heparin is the best choice of anticoagulation agent in most children with cancer, despite its inconvenient route of administration. However, there are no evidence-based guidelines for management of low molecular weight heparins in children with cancer. And these protocols, as we all know, are extrapolated from adult guidelines. What are the indications of unfractionated heparin in a child with cancer who's likely to is undergoing myelosuppressive therapy? And again, these are expert opinions only. When the bleeding risk is high, we use unfractionated heparin. So patient with postoperative or going to go in for surgery, CSVT with bleed, those with coagulopathy, and low GFR or renal insufficiency. So going back to my case, because of the high risk, because of the presence of bleed, We started the patient on unfractionated heparin without bolus, with close monitoring on coagulation profile and clinical symptoms. A repeat MRI with MRV showed stable bleed and some improvement in CSVT. Hence, the patient was then switched to low molecular weight heparin. I'm going to skip this slide. So as regarding the duration of anticoagulation therapy, what is the duration? So CHEST guidelines, although they are old guidelines, recent guidelines also concur, is we should treat VT with minimum of 3 months until the precipitating factors are resolved. And that's very hard for a patient with cancer because most of them do have further doses of asparaginase. They get constantly pulses of steroids, which are also shown to be prothrombotic, as well as they have central venous line. So what we do typically is we continue with full dose or prophylactic anticoagulation therapy till the asparaginase is done, or 4 to 6 months after the last dose of asparaginase, and then watch the patient closely. We don't typically do an anticoagulation prophylaxis throughout the ALL therapy. The next question is how to dose low molecular weight heparin during the periods of thrombocytopenia. Again, there is no consensus regarding how do we adjust the low molecular weight heparin during periods of thrombocytopenia. Most institutions will use a cutoff of 50,000 and 20,000. That means use half dose low molecular weight heparin between a platelet count of 20 to 50,000 and hold the low molecular weight heparin for a platelet count less than 20,000. However, at our institutions, we use a cutoff of 20 to 30. We give full dose low molecular weight heparin for platelet count over 30,000, half dose between 20,000 to 30,000, and hold the dose for a platelet count of less than 20,000. What we don't know is that what is the impact of thrombocytopenia dictated dose reduction of anticoagulation on thrombus resolution or progression. We recently published, Mihir was the first author, we recently published the feasibility and safety of delivering full dose anticoagulation therapy using our cutoff of 20 to 30,000 platelet count, and showed that it was safe and feasible to complete a full dose low molecular weight heparin in patients who are receiving anticoagulation therapy while receiving ALL therapy. However, a caveat is that on Dana-Farber Cancer Institute ALL protocols, most of the clots occur during consolidation when the platelet counts are almost normal. The consolidation on DFCI protocols is very asparaginase intense. We are now reviewing our data for patients who are receiving COG-based ALL therapy protocols and see if we are feasible to maintain the platelet counts, to maintain the full dose anticoagulation for a lower cutoffs or platelet count. What is the platelet transfusion threshold for children with cancer on anticoagulation therapy? Typically, we use a platelet count of 20,000 or above, 20,000 or less. In early days, when the thrombosis is just diagnosed, and especially in life-threatening thrombosis like CSVT, I prefer to give full dose anticoagulation therapy for initial few weeks and would rather maintain the platelet count in the range when I can give the full dose anticoagulation therapy. However, there are so far no data or no consensus as to what should be the platelet transfusion threshold for children with cancer. How to adjust low molecular weight heparin for patients requiring invasive procedures? So there is a limited evidence of safety and efficacy, and current recommendations are to hold low molecular weight heparin for 24 hours prior to procedures to avoid bleeding. And after minor procedures, you can resume low molecular weight heparin immediately. And after major procedures, we can restart only when the risk of bleeding is minimal or non-existent. There are two recent studies, not so recent, but in this past decade, that Leo's group from sick kids have shown, reviewed about 300 and about almost 400 LPs in 22 children, and showed that increased risk of traumatic LP on univariate analysis, but not on multivariate analysis. St. Jude Children's Hospital group evaluated almost 1,700 patients in 133, 1,700 LPs in 133 patients with ALL. And their protocol withheld low molecular weight heparin 24 hours before and 24 hours after LP. And they showed no spinal hematoma in patients who were on anticoagulation, or there was no increased risk of traumatic LP. In fact, what they showed was that patients who were not on anticoagulation had increased risk of traumatic LP compared to those on anticoagulation. And they felt that it was probably the vigilance that patients who were on anticoagulation received in getting platelet transfusion and other supportive care. What is the role of antithrombin monitoring and replacement for children with cancer on anticoagulation therapy? Again, the data is very mixed. The role of prophylactic antithrombin and plasma supplements is not supported by trials like PARCA study. The adult data is confusing as well. An adult retrospective study showed significant reduction in thrombosis in patients receiving AT compared to those without antithrombin. Whereas another retrospective study showed no impact of antithrombin supplementation for asparaginase-induced VTE, and they also shows an increased therapy cost associated with antithrombin supplements. Pediatric cohort studies have shown no effect of fresh frozen plasma in prevention of TE in children with cancer receiving asparaginase, and there are no information regarding the role of AT supplements on either therapeutic levels of low molecular weight heparin in children receiving asparaginase. Now, can the asparaginase be restarted, and when do we restart the asparaginase? We all know that asparaginase is an important anti-leukemic agent, and suboptimal asparaginase therapy is an independent predictor of poor outcome. That was shown first on DFCI 9101 studies, and CAP-ALL studies in adult also confirmed that 50% of the patient stopped asparaginase due to thrombosis, and the event-free survival was significantly reduced in adult patients when they had early discontinuation of asparaginase. The re-exposure of asparaginase, our studies and others have shown that the re-exposure of asparaginase is safe and feasible without any further thrombotic events. We usually start asparaginase after stabilization of clinical status and therapeutic anticoagulation is reached. We continue full dose or therapeutic anticoagulation throughout the period of asparaginase therapy and for about 4 to 6 weeks after. And thereafter, if the need be, we do prophylactic anticoagulation. So our case completed 3 months of full dose low molecular weight heparin. There was complete resolution of CSVT, and she's completed scheduled asparaginase therapy as well as completed ALL therapy, albeit with several modifications. Currently, she's in complete remission. However, the questions are, what is the long-term outcome for this patient? As Ketan has shown, Marie Claude's recent paper, that patients who do develop thromboembolism while on therapy for ALL have poorer survival. But what about the neuropsychological outcome? So we don't have data so far as to how do patients who do develop CSVT and receive ALL therapy in the form of lumbar puncture and or other interventions like high-dose methotrexate have performed later on from the cognitive perspectives. There is a small study of about 9 patients which was published, but the results were quite mixed. So what is the available evidence, and is the available evidence satisfactory to the questions that we are raised? Do I treat with anticoagulation therapy? Yes, maybe, but again, it's an expert opinion. Which is the best anticoagulant agent? Expert opinion. How long do I treat with anticoagulant? We don't have enough evidence. What do I do if the patient is thrombocytopenic? We don't have evidence for that either. How to adjust anticoagulation for LP or otherwise? There is some evidence, I think now. I should change that from no to maybe or yes. And what is the role of antithrombin supplements? Or can patient receive further asparaginase? So there we have that evidence from retrospective studies and observations. And when can I restart asparaginase? No, there is no evidence, or there is no kind of consensus guidelines. Individuals do when they feel safe. So the future research is really required in collecting more data in anticoagulation therapy and prevention of cancer-associated thrombosis in children. I thank all the patients, families, and co-investigators, as well as my funders, and thank you.
Thank you very much, Dr. Atali. Please, if you have any questions, please write them on the chat. I'll try to keep an eye on that. Before maybe I'll ask a couple questions. So, Keithan, first, I'm really intrigued by the data on CVC dysfunction and its effect on survival. So, do we know if it's only the patient who gets thrombosis down the road, or there's even patient with CVC dysfunction will never get a thrombosis, but we still see that effect? And if so, do we have any idea why?
Yeah, I think that's a great question, Marie-Claude. I mean, what happened in that paper was that when we started, doing subgroup analysis, the power was too low, and we were not able to subclassify or see if there was enough effect size for each individual subgroup. So I think we need larger data. I mean, it is quite likely. I mean, then the real question becomes, if symptomatic thrombosis is associated with inferior survival outcome, does that phenomenon get replicated by asymptomatic thrombosis? And there's much less clear evidence around that. So I think that's, in my opinion, that's where the question is going. I know there was a much larger study in Ontario that was running. I don't know if Uma or Dr. Brande or others have any update from that study to see if they found that, because I know, Uma, you've shown that previously as well.
So thanks, Ketan. We just concluded completion of data, and data analysis is in progress. So we'll have more information. So this was a prospective study. We enrolled about 500 patients from all centers in Ontario with both all types of cancer except brain tumors, because brain tumors don't have such a high risk as I've shown. And we are looking at survival as well. So that data is pending. As regarding Marie-Claude's question, there are two things about why the survival of, there is a survival impact of severe dysfunction. One is it could be because the line gets affected. The line interruption in the line as well as therapy may be a cause of it. But if you look at the graphs of survival, both what we had published or what Ketan has done or what Stephen from St. Jude had initially kind of showed the severe dysfunction in brain tumor patients, the graph starts separating out after about 4 to 5 years. If we see that there is an interruption in the therapy, the graphs will be quite separate in early on therapy, but they start separating out. In our case, it was more in the 5th or 6th year of survival. So one of the hypotheses is that because from adult studies, we know that coagulation activation is a sign of aggressiveness of the cancer. Whether those patients who do have developed either VTE or they have like a small fibrin clots, which kind of is a manifestation of thrombosis activation, kind of have an aggressive disease, and that's why they have a recurrence and then adverse events. We don't know that.
Yeah, I agree. I mean, that's where I was going to go to. I mean, I agree with you. You know, what we tried to do then is we tried to flip the data and see how we can sort of take the survival outcome as the first question and then adjust for the risk of developing a prothrombotic event, you know, and that didn't work out because the random forest model just was a mess. So then what we did was, which I think you did too in your SIPC data, is we tried to use the ITR, the intensity of treatment rating, and that nicely separated out the clot patients that, you know, as the intensity of treatment rating went up in cancer patients, the risk of clot was higher. I think so 0 was the lowest and it maxed out for 3 and 4. But yet we were not able to show sort of the effect size of, by the time you subclassify, we were down to very small patients. So I think we might have to ask that question again in SIPC.
Great, thank you for your answers. Dr. Atali, I have another question for you. So
Sure.
we always talk about the asparaginase and its effects on therapy, but I guess there's really a lot of other chemotherapies that could be prothrombotic. So do we have any evidence of what do we do with steroids and anthracycline and other agents that could be prothrombotic outside of asparaginase?
I don't think so. We know that there is so the question is really, is it an association or is it a causative role that these medications play? And then the third thing is that what is I guess when we are treating a patient with cancer and thrombosis, what is the most evil? And we always focus on cancer first. So I think relatively we can manage probably the thrombosis, but the patient needs to have completed anti-cancer therapy to make sure that they survive the disease, right? So I think even asparaginase, for the same reason, we don't want to hold it for a longer period of time, and we want to complete the schedule as much. But the question is very, very, very relevant to say that how do we mitigate? Can we change the protocols? Can we kind of adjust the doses? Even as you know that the data regarding is dexamethasone less thrombogenic versus prednisone, that hasn't spanned out. Can we separate out asparaginase from steroids, because concomitant asparaginase and steroids were shown to be associated with thrombosis? But again, we based our protocols for ALL and other cancer on last 3, 4, or 5 decade studies. And it's very difficult to undo all those things and try to develop absolutely new backbones of therapies, where again to collect that data. And I think the problem with pediatric, I mean, you all know that, I don't have to tell you, but the problem in pediatric thrombosis literature is such that we don't have as much caseload, fortunately, which is good, but that affects our power, and that affects our conclusions that we can reach from these studies.
Sorry, can I add something there for a quick second?
Yeah, go ahead, Ketan.
Okay, no, I just, if I may wear the leukemia hat for a quick second, you know, so I think that's a very intriguing question. I mean, you know, the other area of our focused research is asparaginase, and our center was probably among the first, you know, to start doing routine levels. And we found that our levels of asparaginase are about 10 times the upper limit of normal. And the Europeans have been consistently showing that they can reduce the doses of asparaginase without compromising survival. So I think that really becomes a very challenging question, that, you know, can we get away with a much smaller dose without compromising survival and reducing all toxicities of asparaginase? So I think that could be a huge debate. So.
Yeah, and actually the DFCI study currently is doing that. So their current study, which they will be closing, and I think Mary Cloud, you know that you're still using the FCI protocols, and I think
they want to enroll like 10 more patients, but I think really they'll close enrollment pretty soon. Yep.
Yeah, and I think they have quite interesting results, so that would be good when they publish that. Yes.
So it's 4 o'clock. I had a couple more questions. Jesse, do we continue, or do you want to stop?
If you guys are available to continue, I think that would be great, as some questions came in.
Okay, I'll go, and then you stop me when you need to go. So Dr. Alperin from British Columbia asked, she says, thanks very much to the speakers. Dr. Atali, questions for clarification regarding your practice around secondary thromboprophylaxis in patients receiving asparaginase. Since the asparaginase is intermittent throughout the protocols, do you prophylax with full dose anticoagulation for a time, for example, for weeks, post each asparaginase dose, then drop to low dose in between asparaginase doses?
Hi, Jessica. That's really how we kind of will do in patients. I think when we were at Center for DFCA, it was easy because there was a 30 weeks phase of asparaginase. And so you could continuously treat the patients on low molecular weight heparin and then kind of stop after 4 to 6 weeks. But with intermittent asparaginase, that's exactly how we would do. And again, it depends on what clot it is and how you're going to be, like how serious it is, and if there are any other clots. So if you're just dealing with a small clot, you may not want to prophylax in between, but if you're dealing with like CSVT, I'll definitely prophylax it.
Great. I have one more question. What is it from Dr. Liebman from TIO? What is your practice after 6 weeks post asparaginase? Prophylactic anticoagulation or no anticoagulation when the port is still in place?
Typically, I would say no anticoagulation because it's a huge quality of life issue for the patients. So we just watch the patient. And this is a major problem when they have a right atrial clot or a line-related clot. But we choose, and Mihir and Anthony would also concur with me, I think, that we choose not to continue with anticoagulation and monitor them closely.
Sorry, do you mean if there is a known previous clot or any prophylactic, primary prophylaxis?
I think the question was about the secondary prophylaxis, right, Meera? We don't do any primary prophylaxis unless it's highly indicated.
So Meera says yes, it was for secondary prophylaxis, when it clot happened already.
Right.
So thank you both very, very much. And thank you all for attending. I think as Jesse just put on the screen, there's the link if you want to listen to the seminar recordings, and we'll see you next time. Thank you very much.
Thank you. Thanks for inviting. Bye.
Thank you. Bye-bye.
Bye.